I'm Rob Carson. I'm now direct the Dup15q syndrome clinic at Vanderbilt, so here in good old Nashville, Tennessee. Honestly, it's my pleasure to be here. I'm somewhat humbled to share a stage with Ron and Shafali because, you know, they're kind of my phone of friends when things get challenging, and which is good, because the nice thing about sometimes being in a small community is we know a lot of people and we know each other and we play well together. And so while for me, sitting up here and talking about epilepsy is easy, doing a welcome to Nashville presentation actually was a bit more challenging. So I did what most of us would do in this situation, which is outsource it. And in this case, to my 16-year-old daughter. So if anything looks funny or font looks weird, I just count that as being trendy. So of course, if there's still time and you need to look at things, you know, the pre-music was some Johnny Cash. So the Country Music Hall of Fame is a very interesting place to go. Lots of interesting things. One year they had like all the sequin jackets of the past, which was really quite fascinating. So downtown, if you haven't figured out, I know Shafali has, there's lots of honky tonks and there's music, and just by moving up and down the sidewalk, you can listen to many people who are unbelievably talented. The Wild Horse Saloon is a place where you can actually get a quick line dancing lesson and then join other people on the floor line dancing if you're brave enough.
Shafali, did you do that last night by chance?
Not line dance. But I did watch a band and request the music, and be fun.
Oh, I jumped ahead. Gotta go back. So Grassmere is the Nashville Zoo. Obviously, it's a zoo. It has lots of animals. I haven't been there in a minute, but there is apparently kind of an open area for the kangaroos. And if the kangaroos leave the grass, they are fair game for petting and interacting. If they don't leave the grass, then they'll yell at you. The Parthenon is in Centennial Park, which is right across the street from the Vanderbilt campus. Nashville apparently is the Athens of the South. So for the World's Fair way back in the day, they built a replica of the Parthenon with a full-size goddess Athena. You may have heard of Nashville hot chicken. Maybe if somebody wants offline, we can tell you the origin story of Nashville hot chicken, but Hattie B's is kind of one of our go-tos. I can warn you, though, if you're really brave with really spicy things, I don't know if I would not go full, like, level 5. Of course, just up the road from here, we're not too far away from the classic, where the newer Grand Ole Opry is. The Ryman Auditorium is the picture on the left, which is the classic historical venue for music. If you ever have a chance to listen to anything there, I would recommend going. It's a cool venue. And then out in my neck of the woods, in kind of the western part of Nashville, is the Loveless Cafe, which even a few years ago, the Biscuit Lady was on Good Morning America. So it's one of those well-known Nashville places. And then I think now this is, and then downtown there's also the pedestrian bridge that just gives you a nice view of the river. You can see the river boats and, you know, all the other fun things downtown. And then, of course, go daughter. We are the home of the Nashville Preds, and she's become a terribly scary hockey fan. Even there, ironically, yeah, she's missing teeth. She's 16 now. She does have all her teeth. I myself don't, but that's another story. Now, this is my one moment to be a bit self-serving, but I put this up because people were discussing the location of the clinics, and I think you can see here we are in Nashville, and this beautiful red blob just represents states I have a medical license in, which means I can do telehealth in any of those states. And I can do that because of the Angelman and Dup15q foundations supported that. So just, it's good to have people that are thinking broadly about how we can do things and how to help make it easier for people to get to clinics and get the additional kind of specialty care. Anyone that's talked to me for more than 5 minutes knows it's not uncommon that I go off the rails. I think if I'd leave you with anything, would just be to know that there are a lot of us, and I think I could speak for Ron and Shafali, that probably don't go more than a day, if not a few hours, without thinking about something related to chromosome 15q. And so maybe there's just 3 of us on the stage right now, or still in Boston, but there's a lot more out there. And I was, of course, because I consulted a 16-year-old, that meant as of 12:30 last night, there was not a presentation. So, I was somewhat thinking about, what to say. And of course, I was standing in my bathroom staring at the wall. And it just happens we have a little cross with the Serenity Prayer. And I think many people know what that is. So I won't read, all of it. But, one of the lines is having the serenity to accept the things I cannot change. And then I think about the scientists here, and I think for many of them that we listen to on Tuesday and Wednesday, I don't think their serenity comes from accepting the things they cannot change. It's figuring out ways to change them. And whether that's hearing about a potential for a new drug for Angelman syndrome that could be an oral medicine, or now rolling out a clinical trial in Dup15q. So, things are going to keep happening, and I have no reason to expect that that's going to stop today or tomorrow. So, welcome to Nashville.
Thank you, Dr. Carson. So this session's going to look a little different than anything else we've done. This is your opportunity, because several of you have said to me, I can't get to a clinic. My insurance won't let me go to a clinic. And we're rapidly working constantly on trying to get clinics open in the right spaces. But one of the things we're going to do right now is there are some common questions that Jackie and I hear on Facebook. We're going to ask a few of those to the panelists, and then we're going to give you guys a chance to ask questions. Now, for fair warning, please, please, please don't share super specifics about your child. Obviously, if you want to say something like, my child, we're dealing with this, but we want to make sure it's effective for everyone. I know these are like it's so great to have your ears. So we'll try to keep it very general, if you don't mind, just so we don't continue and for HIPAA too. I don't want anybody to have to share something too personal. If you do, they'll just cut the mic. No, I'm just kidding. Just kidding. So welcome. I don't think there's anyone that y'all know. Shafali, you want to introduce yourself? I think Dr. Carson just did his. You guys just met Dr. Thibert. I think everybody knows you, but just in case.
Sure. Hi. I think I've met now many of you, and I just have to say it's amazing to see so many families and kids. Holy cow, the first family meeting I went to was 6 years ago, maybe even 8, and there were a handful of kids and parents. So this is just the beginning. It's really exciting. So anyway, I'm Shafali Jeste. I'm a child neurologist. I'm chief of neurology at Children's Hospital Los Angeles, and have been fortunate to work with the Dup15q community for almost 10 years now, both through clinical care and research. And we are one of the national clinics at CHLA.
And everyone heard that Dr. Carson is from Vanderbilt. Dr. Thibert, do you mind just giving a 2-second where you're located in case anyone missed that?
Oh, sure. So I'm at Mass General Hospital in Boston. I was just saying yesterday, we've had our clinic open 13 years now, 13 and a half. So,
yeah, thank you.
Yeah.
Thank you. I'm going to start with a question you all may be surprised about. One of the things we hear a lot that families are learning more about is something called CVI. Can someone explain what CVI is and maybe some basic symptoms? Because a lot of families will say, I don't think I've heard of CVI, but I'm hearing more and more about it. And Shafali, you may be able to even share something that's happened near you as well. Does anybody want to take that one? Just butt right in.
Sure, I can take that one. So cortical visual impairment is CVI, and it basically means any visual impairment that's rooted in the brain. So that's really general, obviously, right? To be honest, it's a diagnosis that for a long time we were unsure about because, as you can imagine, it's hard to really know where in the brain something might be located in terms of affecting things like vision and visual processing. But over the last 5 to 7 years, there's been a lot of appreciation, even in like the ophthalmology world, that CVI is a real thing, and it really does affect the way that kids develop and learn and engage with their environment. And in fact, when I started seeing kiddos with Dup15q, I was really struck by the fact that it looked like the way they visually kind of inspected their environment, the way they just interacted with the world, it looked like they were not processing visual information the way, maybe a typically developing kiddo might, or even maybe a child with a different genetic condition. So it's something that many of us have talked about. Ron and I started talking about it way back when as well. And I was lucky that actually this year I was able to connect with a phenomenal neuro-ophthalmologist at Children's Hospital, Los Angeles, named Melinda Chang, who actually happens to study CVI in kids with neurodevelopmental disabilities, which is a jackpot. There's like 3 of her, I think, in the world who do this work. And so we actually wrote a grant a few months ago to study CVI, specifically in Dup15q and Angelman syndrome, and it just got funded a couple of weeks ago. So you might have heard her. She gave a webinar. That's good timing. So she gave a webinar about CVI, which I learned a lot as I was listening to that talk, and we can repeat it. For us, we just found out we had gotten funding when that webinar was scheduled. But anyway, so we will be studying kiddos at CHLA, looking at cortical visual processing, to really think about, are there kind of interventions that we can implement for our kiddos. I think probably we'll drag her to the next science meeting and family meeting and maybe be able to expand the research outside of Los Angeles. But if you're interested, we can definitely tell you more about that.
One of the things I liked about that, and I am not a clinician, you guys probably all know that by now, but one of the things I love from talking with one of our parents is that how surprised they were when they found out. We talk about seizures and we're always working on the things immediate and the emergencies, but they were so surprised at one of the conferences that their child was just having incredible behavioral issues. They were not wanting to work with the person we had here, and all of a sudden they realized the carpet was so busy, it was driving their child's vision just absolutely overstimulating. Yeah.
And again, I learned this from her talk, actually, around interventions. There aren't sort of formalized interventions for CVI, but it turns out that you can make modifications in your environment that can actually just help kiddos who have CVI, things like keeping solid patterns, having the structure of their physical environment be consistent so that there's not a lot of change going on, because that can be really sort of anxiety provoking and challenging, things like that. So anyway, for those of you who missed it, I think did you record that webinar to replay? Otherwise, we can get Melinda back to do a Q&A with families if that's of interest. But really the goal is to kind of understand it better in Dup15q so that we can think about interventions.
Yeah, that's great. We actually, if you're wondering where that is, if you're signed up for our email, you should just search in your inbox, Ask the Expert, and that one has been resent to you guys. If you don't see it, email us, we'll happily send it to you. Any other comments from the panelists about CVI?
For just kind of as a practical point, like Shafali was saying, there's not a lot of treatments, but if you think that your kid has it, definitely get the diagnosis, because definitely in Massachusetts, but probably a lot of states, like that's what qualifies you for vision therapy and for orientation mobility therapy. So it's kind of like autism, like you have to call it that to get the services, which is kind of weird. But just from a practical standpoint, if you think you have it, if doctors have said, yeah, it looks like CVI, like get the diagnosis in writing, then that'll qualify you for services.
That's great. That's great. The next question that comes up a lot is, how can I get my child an autism diagnosis? Because they want to get services, how can someone get that diagnosis? Any comments from our panelists on that?
How long do you have?
You can have the rest of the time.
No, I will not. You guys are experts in so many areas. I want to give them the mic. The short answer to this is that, so I want to make one sort of big point about this, which is that, autism is a developmental and a behavioral diagnosis, and it's based on very specific behaviors that a child or an adult exhibit over time. And the way we make a diagnosis is based on observing I'm going to say child throughout, but this absolutely applies to adults as well. So it's observing a child and getting a really comprehensive history from a caregiver who has spent the most time with the child. So it's history and it's direct observation. There are a lot of standardized tools that we can use to help elicit behaviors of autism if sometimes in a 45-minute clinic visit you can't see what you need to see. And there's also standardized interviews that we can do with families, some of which take hours to do, that just really go through development. And those are helpful sometimes, especially for older kids, if we're trying to really understand early development and really get a good sense of history. So there are tools out there. But we as clinicians, as child neurologists, child psychiatrists, developmental pediatricians, I would argue even general pediatricians, we can make a diagnosis of autism based on knowing what the behavioral signs are in a clinic visit. It doesn't require all those standardized tests. Having said that, there are certain states and school districts and things that require certain standardized tests to be done and documented to cover services for autism, and that's very region specific. I will say in California, for instance, it used to be that the school required an ADOS, which is the Autism Diagnostic Observation Schedule. It's a long name for a standardized test. Some of your kids may have done one. We did the ADOS with a lot of kiddos that do Dup15q for our studies. You may have been those. They required an ADOS for an autism diagnosis, and many of us clinicians pushed back on that because the ADOS isn't always a great measure for, our kids, especially who have, different profiles. And it's also hard to get an ADOS done. And a lot of clinics, especially in California, don't take insurance, and so you're paying out of pocket to get an ADOS. There's a lot of pushback, and they actually have modified the requirements. And now the requirement is that it's a clinician rater called the CARS, which is the Childhood Autism Rating Scale, and it's something that the clinician can fill out in the clinic when they're interacting with a child and talking with the family. So I use that as an example because that makes the autism diagnosis much more accessible for families. We can talk, down the road about what autism actually is and those sorts of things, but what I'll say is that we know that many of our kids with Dup15q meet criteria for autism. And, for better or for worse, an autism diagnosis does help garner certain types of services. I wish we could say to insurance providers and schools, this child has Dup15q syndrome, and because of that, they need ABA and speech and OT and PT and all those things because they need developmental supports. Unfortunately, many systems need the behavioral diagnosis on top of the genetic diagnosis to really provide those services.
Anything else from the panelists on that? Okay. All right. Dare we go into the crowd, Jackie? Look at the hands. I saw Jen Gunn right away. Jen with her white shirt on. I saw she's so excited. She's like, this is my Mecca right here.
Hello? Okay, sorry. My question more pertains to cannabinoids. So Epidiolex is just one cannabinoid, and I know a lot of parents hear about THC being another one, but there are over 100 cannabinoids, and my question is do we have any research on the use of other cannabinoids? Because I know there are a lot of families that use full spectrum hemp oils and have success, and that you guys can't comment on that because it's not FDA regulated, but medicinal is in states that it is permitted. So I'm wondering what research, or if you guys have experience with some of your patients that are on other cannabinoids or medicinal.
So I'd first say we can talk about it. I can't write a prescription for things that aren't FDA approved, but this is something we've been interested in going back, right? At the time when initial CBD was talked about a lot, and I think there's a lot we don't know. I'll move your number up a little, that in cannabis, there's over 400 cannabinoids, and CBD is one. There's THC, as Ron said, which is the part that makes you high. Of course, for recreational purposes, that's fine, but as a treatment, that's kind of what we try to avoid. There is CBDV, which is cannabivirin, I probably pronounced that wrong, which I know has been studied. So I think the moral of the story is we don't know. And my only caution, and I personally have no issues with using any of the artisanal CBD products. I think it's just one of my observations is, for example, for Epidiolex, if I prescribe it, we're required to check liver enzymes every 6 months. Where when, people would talk about, oh, we're using this version of CBD, I don't think we ever checked it. Now, I don't think it's a huge problem, but it's always just important to keep in mind everything that we're putting in our body has side effects and potential interactions. So my advice is talk to your providers about it. Again, I have no issues discussing it. I think some people do get a little nervous about it, but that was the long-winded version of we don't know.
Shafali or Ron, do you have any comments on that?
Ron, I had one sort of take-home point, but if Ron wants to.
Yeah, oh, no, go ahead. Yeah.
So I think it's a great question, and I think a lot of our families take some CBD product. My two sort of pleas to you are this. One, if you're taking anything not prescribed, please tell your provider. Because, and I know sometimes I've had patients who have not told me because they're worried about whether there'll be judgment or whether I'll, sort of give them advice against using it. And I'm always really clear with my patients. I just want to know, because I truly believe that anything you're giving your child, you're doing to help them. And I'm here to help them too, so let's do this together, right? And so the reason I want to know is that drugs interact. And CBD absolutely can, and I don't know if Ron talked about this earlier, but CBD can affect levels of certain drugs like clobazam and things. And so we need to know so that we can manage the meds that we are prescribing. So that's one. The second is, and there should be no judgment, first of all. And if there is, maybe you're not with the right provider, right? Because we need to work as a team here. So that's one. The second piece is, if you're using CBD, have a clear, whoever's providing it, or if you're using it sort of based on suggestions that have been given to you by others, have a clear idea of what it is you're trying to treat. Because the reality is, we use CBD and we say, oh, it's for behavior and sleep and mood and this and that. And then it's sort of hard to know if it's really working or not. So have an idea and you can have this discussion with your clinician. What's the target? Say it's insomnia. We're going to try CBD for sleep issues, right? So then you have something that you can anchor your monitoring with and say, we're going to try it. And in 3 months, we're going to see if the sleep is better. And we've measures of sleep. I mean, I'm using sleep as an example, but whatever it might be. If it's mood, if it's number of, repetitive behaviors, if it's aggression, whatever you think it might be potentially helping with, have a plan of what that's going to be and measure it so that 3 months down the road, you can decide if it's actually working. Because what happens otherwise, and this is not specific to CBD, is I often see kiddos, actually older kids with the Dup15q, in teenage years and older, and they come to me for a second or third opinion, and they are on a list of meds, like 20 medications, because everyone's added something. And we haven't had a rational plan for when to start and when to stop, because we don't really know exactly what we're treating. And that leads to side effects and interactions and things that aren't safe for our kids either. So those are my two big sort of pleas to you guys.
Yeah, that's great. Dr. Thibert, anything on your side?
No, not much. That pretty much covers it. The only other thing I would kind of add as a third plea is just to make sure you can trust the source of whatever you're getting. So, because wherever it comes from, you have to make sure that what they say is in it is actually in it. You never know if there's pesticides, those kind of things. So if you're making something yourself, you obviously know what's in it, or otherwise just kind of make sure it's a trusted brand or a trusted provider that whatever it says is in there.
Yeah,
it's really important.
Great.
Yeah, and not related to CBD, but Shafali makes a great point with just these treatments. One just kind of not just for CBD, but we do see kids that can get put on this and this and this, and then they're on like 27 things. It's always important too when you go to a doctor visits. If they don't bring it up, then it's good to say, is there anything that we can get rid of? Like it's always, like ideally the providers would be thinking that already, but you can always bring that up too and just say, is there anything here we don't need? And sometimes the answer is no, you need all this, but sometimes it's, I don't know if this is really helping. So it's always good to, we always want to have kids on, or adults on what's helping, but off whatever isn't doing much, just to really minimize those interactions.
Yeah, great points, great points. I saw a hand right over here. I think was yours the first one? Promise we'll get to other, well, I
Carrie.
can't promise that, that's not true. Yes.
Let me just, real quick, so Jen wanted to just kind of circle back real quick, and I'm going to just clarify a little bit. So one of her specific questions is just, is there specific Dup15q research that looks into cannabinoids? Besides just CBD Epidiolex, so the idea that it's broad spectrum and that, how they distill this, Jen, didn't do as much research as you, but how they create the Epidiolex is a little different than others that you can get in the market.
I don't know of any. I will say there are ongoing CBD trials in epileptic encephalopathies, and I think that some of those trials don't exclude for a genetic diagnosis because most of those kids have some genetic diagnosis. So that's a way to get into a trial, and there are some now emerging trials in autism. CBD, there's one trial that's looking at CBD for sleep, for insomnia. One's looking at CBD for aberrant behaviors in autism, but we don't have any trials in Dup15q.
Okay, here we go.
All right, this kind of goes off the reducing the medications. If the patient has been seizure-free for a couple years and the neurologist now wants to reduce the seizure medication, what are your thoughts on that? Because talking to other parents, it's, first thing you hear all the horrible things that have happened when they start doing that. But what do you feel? Is it a good idea or hold out, what have you?
That is an excellent question, and I think it's a hard one to answer too. I kind of go with this philosophy of when using medicines, we use as much as we need, but not more. And it's sometimes hard to know where that fine line is. If somebody is seizure-free and not having side effects or obvious side effects, then it's a little harder discussion. Because the risk is that if we do wean something and seizures come back, sometimes we do need more medicine than we were on before to get things back to where they were. That being said, some of our medicines we use, for example, zonisamide and topiramate, can have effects like cognitive blunting. So is there side effects that we're just not necessarily appreciating that if we remove those medicines that we may see additional improvements because of the side effects of the medicines? So honestly, there's not a clear right or wrong answer. Sometimes we'll wean something off and somebody does great and there's no problems. Other times we wean something off and somebody has a seizure and then we're like, oh, well, we can't do that. I do think we're always worried for somebody that has a symptomatic epilepsy, and that just means you have seizures because of either a genetic cause or, say, a structural cause, that those are people that are less likely to outgrow epilepsy.
Any other comments from the panel on that?
No, that's exactly what I was thinking. The other thing that I think plays into is age. Like if someone's about to hit puberty, that may not be the best time to get rid of medicine. So it also depends on kind of where they are. And then if the only other thing I would add is if we do, if it is going to be one of these elective kind of taking off of medicine, then it would just go really slow, and that way if something starts to go wrong, hopefully it will be very minimal and then you can just go right back up. So if it is like seizure-free for years, everything's good, and it's like, all right, let's try. It's always good to go really slow just to be extra safe. When you have active seizures and you're actively going up and down, you want to get kids off stuff. If there's side effects, you want to get them off. But when it's more like things are good and let's try it, just go really slow.
Okay, I'm gonna take one over here, and then Jackie, wherever you are, you can take the next one with your person. We got one right here.
Hi. Wanted to hear a little bit about the combination of VNS, vagal nerve stimulator, and RNS, which is the responsive neurostimulation. I know they're doing it in pediatric patients, and I've read some studies that they've had, but long time VNS, and we're trying to get rid of medication because it's just having such. So I'd like to hear about the combination and if you're seeing that at all with Dup15q kids.
Anyone answer on that? So I think she was asking about the VNS versus RNS.
No, VNS and RNS.
Yeah, just in case people didn't hear.
Yeah. So we don't have too many that with like double stimulators. the few kids that we've had with VNS that we've switched over to the RNS, we usually kind of take the VNS up with the RNS in, but the RNS is really like I said in the talk, it's over the last couple of years, they've kind of not switched, but all kind of added to it. It's not just for kind of stimulating that like just one little area of the brain that's having seizures. They can stimulate the thalamus in the middle of the brain directly. And but what's different about the RNS and the VNS is that the RNS will collect EEG data and then actually kind of fire off the pulse when it sees a seizure starting. So that often happens before you see the seizure clinically. So it they haven't kind of finished these studies and kids looking at all this, but it does kind of feel like that it's going to be more effective just knowing that it can actually record the data and then that's why they call it RNS. It responds to the EEG change and fires it off. So we've been using it more and more. I don't think we have anyone with Dup15 yet, but I'm sure we're getting there. I don't know if you guys have any other thoughts.
Yeah, I think it's still the same of just having, especially in pediatrics. It's been we don't have a ton of patients at least here that have RNS. We have a fair number of VNS, but just so the combination, I just don't know.
Anything else, Shafali, for you?
I think that sort of a big picture answer to that is that epilepsy management is evolving really quickly, and I think the next frontier over the next few years is these kinds of non-pharmacological interventions. And RNS is, our hospital does not do a lot of RNS yet, but we are trying to expand that program over the next few years for some of these really intractable epilepsies, because as Ron said, it's an incredible technology. It literally is like you're detecting seizures in the brain, and the second it's like a machine learning, like the machine detects the abnormal activity and then essentially calms the brain before the full clinical seizure happens. And so it's a really incredible technology that works quite well in kids that get it, but there's still some time needed to really get enough data. The likelihood that there's going to be a trial specifically in Dup15q for RNS is unlikely, but there will be more pediatric trials and just more pediatric experience over time.
Okay, Jackie, back to you over there.
Hello? Okay. So my son's neurologist from Johns Hopkins of Maryland said that one of the medications he's on, which some of your kiddos might be on, the lacosamide Vimpat, have you heard that it might be discontinuing? Because that's what he has told us.
That the medicine is being discontinued?
He has heard that eventually it looks like it's going to be discontinuing. So he's tried to...
I'm going to take from their facial expressions. That's new.
Right. Yeah, we use lacosamide a ton, even in really young people. Sorry.
No, it's just harder to back.
Yeah, we use it a ton, so I'm not aware of anything about that.
Okay. Anyone else?
No, and in the epilepsy world in general, it's probably one of the 2 or 3 most used medicines. They use it a ton in the adult side.
Okay. Thank you.
Okay, good. Hopefully that's one relief today.
Yeah, and Shafali just made a good point. I just stole the mic, though. There are lots of, for once medicines move into generics, there's lots of different formulations that are being used. And so we definitely run into switches where it'll be like, brand A is no longer making it, so we need to switch you to brand B. But again, I'm not aware that the drug itself is going away, nor would I know why. It's not something where, one of the other drugs that was mentioned, retigabine, people used to turn blue. And so it's been taken off the market. So I've never seen anyone have anything with Vimpat. So.
Do any of you have any thoughts on IVIG as a seizure treatment?
It's a good thought. It's like I said in the talk, we use prednisone a lot. As an anti-inflammatory. With IVIG, it's unclear if it's clearly like an autoimmune epilepsy. Then yes, it works great. For non-autoimmune, there's really not a lot of data just because it's not so much anti-inflammatory like the steroids are, but we've it definitely gets used here and there, but if it's not a pure autoimmune, it's really unclear how much that helps. Versus we know that the prednisone, prednisolone, steroid type medicines can be really helpful. I don't know if you guys have any more experience with IVIG.
I mean, just in terms of the kind of immunomodulatory treatments, I mean, our center, I've seen a real rise in treating sort of when epilepsy gets, not as a sort of maintenance, but like when things get really, sometimes seizures just, they beget seizures. And so you start getting, something happens, maybe the child was sick or not, you don't even know. And then all of a sudden there's like a flurry of seizures that are really hard to get on top of. I'm seeing more and more our epileptologists use, a short course of high-dose steroids to just kind of calm things down. And it seems really, it can be very effective. We also are not using IVIG, but I think that the idea of IVIG is kind of still in that vein of like, is there some secondary inflammatory process that's kind of making things worse in the short run?
All right, Jackie, back to you over wherever you are.
Hi, this is just a question regarding the community. Would it make any sense through the Alliance to make some sort of database regarding all the EEGs that we do with our kids? Because we all do like regulars, or we're in an emergency stuck in the hospital for 10 days. And, now I've done so many because our son is 10. So would that be of any use to all of you to process all this data? Or is like something, I don't know, it's just something I was wondering.
Yeah, I love that you're asking that question, and the answer is yes. It would be amazing to have EEGs in a registry. I think that it requires a level of resource and organization that is not trivial, because we've tried to do this in other conditions, because we, and we'll talk about it later today, but when we look at EEG as kind of a biomarker of different aspects of a condition, it's nice to have a lot of data. When we looked at sleep EEG, in that we were doing a study looking at sleep EEG and Dup15q, which we published, again, I'll talk about it later this afternoon. We actually had to have parents like mail us CDs of their EEGs, and all of you who did that were amazing, because you did it, and we in the mail had these hard copy EEGs that we'd upload and then figure out how to harmonize. It would have been really nice to have them all, in a registry. There's some challenges to it, unlike neuroimaging, like having an MRI registry. MRIs are usually uploaded into an electronic medical record into the system, so it's easier to pull out. EEGs don't get stored that way. It's so much data. And so often in institutions, the EEGs are stored locally, and then the reports are put into the electronic medical record, but not the whole EEG. So like in our institution, any recording that's more than 6 hours, they only save snippets across time. So they have like a set protocol for what they're saving. The rest gets discarded because there's not enough hard drives to store days and days of EEG data on everyone. But I think it's a project worth considering, because it would be helpful. I don't know, for you guys from an epilepsy standpoint, Ron, like, would it be helpful to have that to look at, kind of epilepsy features?
Yeah, it would definitely be helpful, but just like you said, it's the logistics of it are really difficult. Yeah.
We get calls a lot, and people say, hey, I've got my ladder account, can I put EEGs in it? And we're often saying, we can't do anything with your disc, because each hospital may have its own system too. So that's such a great question, because we get that a lot about how to store these. Sorry, Ron, did I cut you off?
Oh, no, that was pretty much it.
Okay. Okay, good. We got one over here.
In terms of EEGs, is it common to see seizures in a child, but no EEGs capture that? And what are some tips maybe to help with that?
So yes, it can happen. For example, in frontal lobe epilepsies, only about 15% of seizures show up on the EEG when they're happening. So what can be, I think, helpful is, seeing lots of events. I'm a huge advocate of making videos, because sometimes even when we have videos of somebody at home and then we'll bring them into our epilepsy monitoring unit, and you see a spell that looks identical to everything else that's been seen before. Now, that doesn't necessarily mean it's a seizure, but when we look at all those details, sometimes there might be enough evidence to suggest, we should probably treat this like a seizure and see if it responds. Now, a therapeutic trial is not definitive evidence because things like benzodiazepines fix a lot of different things. But yeah, sometimes it can be very challenging.
Any other comments from the panelists on that? Okay, Jackie?
What was, for the question, was it that the events were happening during the EEG and that they didn't show up, or were the events not happening on EEG?
The events happen, in our experience, literally right before we go in for them or right after, and then, or even EEGs don't show any abnormal anything is what they're telling us, and so yeah.
Yeah, so I mean, the ideal is that we want to capture a seizure on an EEG, which, as to your point, that often how we joke that sometimes like EEGs are therapeutic because, a child will be having all kinds of seizures. They come in, are admitted for 3 days and no seizures, right? So, and so I think that the way that I approach this if a child's having seizures is we try to figure out like what the pattern is and what the frequency is. Like if your child's having seizures once a month, then the likelihood of capturing something on an EEG is low. And so then the question is, why are we doing an EEG? Is it to get background information? Is it to look at sleep? And we can do the EEG for those things, but we're not expecting to capture a seizure. If a seizure is occurring, say, 2 to 3 times a week, then I'll admit a child into our epilepsy monitoring unit to get enough days where there's a high likelihood for capturing a seizure. So it really depends on kind of the frequency. But there are circumstances where it's not going to be feasible. The last thing I'll say is that we do have also technology to do ambulatory EEGs, which are ones where some of you are shaking your head, you've had them. They're no fun either, but you wear a little backpack and go home with the EEG to sort of try to capture an event in the home environment, which might be a place where you're more likely to get an event. And so all that sort of decision making comes from getting a sense of when seizures are happening.
I'm going to hijack and tell you one question we get a lot on the Facebook page is exactly what you just asked. Can any of you speak to what can look like a seizure? And if that's way too broad, but a couple of you have called when I've got families in the ER and they're like, they're not capturing it. We know this is happening. Is there something that could mimic a seizure that families should be aware of? If maybe they're in a more rural hospital or hospital that's not as attuned to what Dup15 is?
Yeah, there's lots of things, which makes it a little harder. Some are simple, like things like what we call stereotypies, and that's kind of falls in the category of funny things kids do. They look stereotypical, but like the happy dance. Sometimes it's clear, this isn't anything to worry about, but sometimes it's not clear. Tics, syncope, passing out spells. Sometimes people pass out and they have twitching, and it looks like a seizure. What else? Nocturnal events, night terrors, benign sleep myoclonus. So to point out, there's a lot of things. But I would go back to point out that epilepsy is a clinical diagnosis. And we have lots of people who there's no question whatsoever they have epilepsy, but every MRI they've ever had is normal, every EEG they've ever had is normal, every genetic test they've had is normal. So it can be challenging, and obviously, ideally, we know exactly what we're treating, and sometimes we don't, and we use our best judgment.
Yeah, and outside of the neurology realm, like GI, reflux can give you like seizure looking. You can stiffen. So sometimes even GI issues can look seizure-y on video.
So, Carrie, back here, I have 2 questions of families who don't want the mic, but Ron, you just touched spot on the first one. So can you talk a little bit on the panel about GI issues and how they can exacerbate seizures and kind of what families can do in a treatment plan in that situation?
Oh, sure. So it's one of those things where, there definitely is that big connection between the brain and the GI tract. And then even just on top of that, just being uncomfortable, kids that have, reflux, bad constipation, it'll, can affect sleep, but also just the discomfort, like anything that just throws off the rest of the body, we can see exacerbate seizures. So I was talking about how sometimes those GI symptoms can look like seizure, but they can definitely exacerbate. When we'll be getting a history and knowing that seizures have increased, and then we find out that like over the last couple of months, the bowel movements have gone from once every couple of days to like once every 6 days, and then that really kind of often correlates with it. So it's just one of those things where and part of it is us, like we prescribe medicines that constipate. So that's another piece of it. But really just kind of keeping the things moving through the GI tract is really important. It's just in general to have things working better helps with the seizures, but minimizing the discomfort, maximizing sleep, and also kids that are really constipated, they often won't eat or drink as much. Now, if you're starting to not get enough calories and lose weight, that throws things off. So kind of separate of the seizures, it's important to kind of keep an eye on GI issues and really kind of treat those as much as you can to keep that working better, because the better you're going to do GI wise, it's just easier to treat the seizures.
The next one
and
is.
Also,
oh, sorry. Go ahead, Brad. Sorry.
Oh, and there's lots of different things that you can use to treat constipation, but there's a lot of options out there.
The next one I know is also a big Facebook question, and I think Dr. Jeste touched on this a little bit in a webinar we did recently, but a question back here is, what is the life expectancy of children or individuals with Dup15q? Do you all believe that it's a natural life expectancy? Is it a shortened life expectancy? Also knowing the limitations of genetic testing, so we may not have individuals old enough, but if you could speak at all to that, we have that question back here.
It's a great question. I get asked this all the time, and I wish, and I'm going to give the answer that I know is not satisfying, is we don't entirely know. And I think that as we learn more and as we see kids grow up into adulthood, with Dup15q, we do learn more. We don't have, long-standing natural history sort of studies. What I'll say generally is that I think that as I'm going to say this generally with regards to sort of genetic neurodevelopmental disorders, so not specific to Dup15q, but I think we sort of understand this more broadly, is that as we're getting better at earlier diagnoses and even starting to do studies in early, like prevention of epilepsy or treating aggressively, developmental challenges in epilepsy and behaviors and things early on, the expectation as a field is that quality of life and life expectancy are going to improve because we're managing really challenging issues very early on. And even as kids get older, we're just more aware of needs and have more in our armamentarium from the standpoint of medications and, having experience with medications and knowing which ones are safe and not safe and which ones might have longstanding long-term effects that might be problematic because we have information. Like we just didn't have all that information 20, 30 years ago when we were taking care of these kids. So I absolutely, I think we as a field agree that life expectancy and overall, again, just sort of health is going to improve over time. The things that really, I think, affect life expectancy in these kids is seizures, and then other medical co-occurring conditions that sometimes I will say, and I don't have data on this, but I'm saying this is sort of from clinical experience, the basic medical issues that sometimes we don't always stay on top of because we're so focused on the seizures and the developmental and educational needs. I've had a couple of patients with genetic syndromes who in adulthood it turned out had cardiac issues and had some other, early signs of diabetes and things that we see in adults, right? But they weren't getting quite the same level of primary care because the focus was on all the neurological issues and psychiatric issues. And so what I would say, which is not answering the life expectancy question, but I think to get sort of ahead of it, for all of us to be proactive, I think it's important for all of us as clinicians to talk to parents about making sure that you have a really good primary care provider who is still helping to take care of your child and then adult as a full human being and not just focusing on, because we're going to focus on the brain. and on behavior and those sorts of things. But there's the rest of the body that we still need to be making sure cholesterol is in check, right? Because diets can be all over the place. We're making sure that, again, cardiac health is good, that GI health is good, that, just the regular surveillance and screening that we all do as healthy adults, we need to be doing in these kids too.
All right, we're wrapping up in just a second. I promised this lady, and we have one more, and then we'll be wrapping up.
Could you talk about going from a VNS to a complete corpus callosotomy to when would you do DBS or RNS following that complete corpus callosotomy?
In 30 seconds or less, right?
So in general, where a callosotomy is most effective is for atonic seizures. So for somebody that's having frequent drop seizures, that the EEG is consistent, that it's a generalized seizure, often we'll have that discussion of VNS versus corpus callosotomy. And sometimes it's you do a VNS, and if it doesn't work, then you go to a callosotomy. Sometimes it's you go to the callosotomy, and if it doesn't work, you go to a VNS. And then it would be, I think, after that where we would think more about DBS or RNS, which, are getting used more, but still it's still newer technology. So we're kind of still transitioning into it. But again, just a summary for atonic, so drop seizures, the callosotomy is very effective.
Hi. Anything else from the panel on that? I have one final one, and then we have to move on to our next section. Anything else? One question we get a lot, and I think it's super important to ask too, is if a child is not having seizures prior to puberty, is there any research or information on does puberty kick seizures in more? Is it something they need to be more? And is there, of course, the question from this particular parent was, is there anything they can do about it?
To do about preventing it, or?
Yes.
Yeah, that's tough. You can't really prevent seizures if they're going to happen. But with puberty, in general, well, it's tough because some epilepsies will kind of start or worsen with puberty. Some, if they started when they're young, will get better at puberty. But kind of with the Lennox-Gastaut type seizure starting more in that 7 to 10 range, if you get kind of past that and into the early teen years, the odds of that are very unlikely. We've had a few kids that developmentally were doing pretty well, that were verbal, that developed focal seizures with puberty in the teen years. So that's and that really kind of fits with just the autism population in general. There's that kind of early childhood spike, and then there's the teenage spike. So we have seen some, but usually if you're going to get the really difficult Lennox-Gastaut type seizures, that's going to happen pre-puberty. So if you get to puberty, you're probably past that point where you're going to get really difficult seizures. But you can still get focal seizures, but at least those are easier to treat than the Lennox-Gastaut type. Like I said, we've seen a couple over the years, kids that were doing really well, ambulatory talking, no seizures that then develop focal seizures, but they're more just like kind of typical epilepsy that that tends to respond to medicine versus the more tricky Lennox-Gastaut.
Okay, thank you. You guys, can we thank the panelists for this?